Her doctorate in neuroscience at Boston University, performing her dissertation research at the National Institute of Health. Since her graduation, she's worked as an adjunct professor at Marymount University.
There you go.
In Marymount University in Arlington, Virginia. Her interests include animal models of mental illness, in vivo and in vitro electrophysiology, the use of ketamine to treat depression, model schizophrenia, and reduce pain. She enjoys educating scientists and non-scientists alike about brain development and leads seminars and talks about the neuroscience of the unborn. She believes that as people become to understand more about embryonic and fetal development, they will be more likely to support life-affirming policies. So, give a warm welcome to Dr. Katrina Furth.
Thank you. And before we begin, I actually just want to tell you a quick story about last year at Life Tech. I met another professor here. His name was Derek Dorosky. And I just wanted to encourage you guys that the connections we make here are important. So he invited me to come speak at Franciscan University last year. And when I did, I met another of his colleagues who's studying ectopic pregnancies in rats, and specifically trying to move embryonic rats from one horn of the uterus to the other. And so he's doing some really pioneering work in whether we really could save babies from ectopic pregnancies. And what was cool was he needed some equipment for his lab, and I was also in touch with some labs at the NIH that were sort of pulling in. They were professors were retiring, and so we managed to connect, and I got him a whole bunch of free supplies to set up some of this new groundbreaking research. So I wanted to encourage you that these connections that you're making here today are important. And we are here to be resources for each other. Yeah. So it's very exciting that we're here, and I'm just very honored that you gave me the best presentation from last year. So thank you. Okay, so we're going to try some technology in this talk. As long as texting is free on your cell phone, go ahead and text this code. It's my name, Katrina Furth, 260, to that number. And what's going to happen, as long as all the technology works, is I'll be able to ask you questions, and you'll sort of get to answer in real time, and we'll see how people are answering. So go ahead and text that Katrina Furth 260.
Is that case sensitive?
I don't think it's case sensitive. Okay, cool. It looks like most of you look good.
Do you actually send that other number to you?
Can you put that back up?
Yep, sure. How about this? Put your cell phone down on the table when you're done so that I can see that you succeeded.
That 22333 is your text message, right?
Yep, so that's the number you're going to be texting, is 22333. Does it say invalid? Did anyone get a successful message? Okay. Hopefully.
Katrina first session.
Good. All right. Excellent.
I got it not delivered. Good.
All right. Well, as long as most of you guys can vote, we'll be okay.
Join Katrina first session.
All right. Cool, let's give this a whirl. So today I'm going to be talking to you about fetal pain and fetal viability. Again, my name's Katrina Furth. Other than doing neuroscience work, I also have some pro-life background. I started sidewalk counseling when I came to DC about 7 years ago. And just like you were saying with the escorts being very pushy, I stopped when I was pregnant and one of the escorts knocked me down. And I said, okay, this is getting to be too much. So now I work with a group called Young Lives, and they are like Young Life, but they're specifically geared towards teen moms and supporting teen moms, helping them discover the love of Christ and helping them in raising their kids. And just another fun fact, I'm sure most of you guys have seen Manny here. And when he was 17 weeks post-conception, we were actually part of another neuroscientist study to see how much we could see of his brain in utero. So this is actually a picture of his brain at 17 weeks post-conception. So pretty fun. Okay, so today we're going to be talking through a couple of things. Why is fetal viability important? Spoiler alert, there's a lot of laws that are going to be related to viability and the age of viability. And what are the medical barriers in neonatology that sort of limit where fetal viability is? We're also going to be talking about fetal pain and why is fetal pain important? Is it important? And how do we measure it? So let's start with one of these text polls. So this one's simple. True or false? Abortion is illegal after the age of fetal viability in the United States, except in cases of rape, incest, or endangerment to the mother. Oops. Doesn't look like it's working. Hold on a second.
Yeah, we can do that. There's more, so I'd like to get them to work. It's really fun when it works, so. Let's try it again.
All right, there's a chance it might not work. It's not the first time this hasn't worked. So raise your hand if you think the answer is true. Raise your hand if you think the answer is false. Okay, you guys are well informed. It's true. Abortion is not illegal. We'll go through exactly what is the limit, but states can make abortion illegal after the age of viability. Not every state does. So let's talk a little bit about the history. How did we get to this point where we're in a Roe versus Wade world, and those are the laws sort of governing our society at the federal level? So in the 1700s to the mid-1800s, basically all states were allowing abortions in those times before the mother could feel the fetus move. This is called the quickening, when the mother is like, oh, I can feel those punching and kicking motions. But then, starting with Massachusetts in around 1850, states started to make laws banning abortions, and this was all abortions. And so this was a time that was really successful for the pro-life movement. But then, in the free love era, starting in 1967, so not so long ago, in a matter of 6 years, basically all of the states changed their mind. So starting with Colorado, 17 states allowed abortions for rape, health risks, and fetal anomalies. And 4 states, there wasn't even that restriction. It was just whenever a woman and her doctor deemed it medically necessary. The only state that kept a full and complete ban on abortion was Pennsylvania in those 6 years. So then we move to January 22nd, 1973, Roe versus Wade. And I called my friend who's a lawyer, who's actually getting to work on some pro-life legislation. And I was like, what is the constitutional right? Like, where is this constitutional basis of Roe versus Wade? Because I don't see it. And so it's a very broad definition of the 14th Amendment's guarantee to liberty or privacy. And according to the Chief Justice, or the Justice who wrote the majority opinion, while the Constitution doesn't explicitly mention any right to privacy, there were a number of previous decisions that found a guarantee to zones of privacy. And they said that the woman's body was now this zone of privacy. Also that same day, they said that the doctors can use any and all factors in determining whether a woman needs an abortion. So this was, she's emotionally needy, this would be a need. So this was a pretty defeating day, January 22nd, 1973. And it set up this framework that has sort of persisted for a very long time. So basically, in the first trimester, those first 12 weeks, the framework they set up was that the state has no legal interest in protecting the mother's health. So they can't say, oh, you need to do these restrictions in order to have an abortion. And they could only put rules in place that were basic health safeguards that said, okay, we're gonna keep you safe by making this be like a medical provider, for instance. Then the second trimester, which they define until viability, the state has a legal interest in protecting the mother's health. And just so you guys know, viability is this place where a baby can survive outside the womb. So the state can now start restricting abortion in order to protect the mother's health, but not to protect the baby. And finally, after viability, the state can protect the unborn's life, but it doesn't have to. And so now the state could restrict abortion. And 16 years later, another case came to the Supreme Court, and they basically set the age of viability at this point. Missouri wanted doctors to test for viability starting at 24 weeks gestation. And the Supreme Court said, yep, you can do that. You can make the doctors say, will this baby survive? And now that's gonna be the limit. And then finally, the most current federal abortion policy that we're under is actually another case called Planned Parenthood versus Casey. And this was not a win or a loss for us necessarily. Basically, what Planned Parenthood was suing the Attorney General for was the right to keep restricting, or to keep out all restrictions from the first trimester. And the Supreme Court said no. Actually, the state can put in some restrictions, like making counseling mandatory or making an ultrasound mandatory, as long as they don't create an undue burden for a woman. And so this is what we're working with now. Unfortunately, by ruling this way, they sort of embedded Roe versus Wade. They said, Roe versus Wade is okay, we just want the states to have a few more rights. And this was an extremely splintered court. There was actually sort of 3 opinions, and the 3 centrist judges basically said they wanted to side with the states. They wanted to overturn Roe versus Wade. But they said, the Constitution serves human values, and while the effective reliance on Roe cannot be exactly measured, neither can the certain costs of overruling Roe for people who have ordered their thinking and living around that case. So basically, people have built up this expectation that, oh, if I make a mistake, I can just go get an abortion. And they didn't want to undo that overnight. So let's take a poll just by raising our hands. So how many states start protecting the fetus at this age of viability? Raise your hand if you think it's 7. Okay. Raise your hand if you think it's 19. Okay. Raise your hand if you think it's 31. And raise your hand if you think it's 43. Okay. I wish it were 43. The answer is 19. There are a few states that actually protect the fetus before the age of viability at 20 weeks, saying that the unborn is pain capable. And 43 states have some sort of limit. So the most common limits are 20 weeks, 24 weeks, or this age of viability. 19 states have chosen viability. And this is also loosely defined. So in New York State, the age of viability is 27 weeks, which is sort of absurd because, as I'll show you some information on, basically at 24 weeks, more than 80% of these premature babies are living, and without severe disability. Also interesting to know, this also, Planned Parenthood versus Casey allowed states to say whether or not they would fund abortions for Medicaid patients. And 16 states, including my state of Maryland, will use our state funds to pay for abortions. 33 states don't let state funds pay for abortions. And actually 12 states actually even restrict the coverage of abortion in private insurance plans. Which is just good to know. I had never even thought about the fact that my health insurance that we pay into might be providing abortions for the people.
Right.
So just something to consider. It's not just the state, it's also maybe my PPO. So here's a nice little graphic. We're making headway. I feel like this is actually a very exciting time in the pro-life movement because, as Nick was saying earlier today, there are 7 states that have introduced these heartbeat bills, and even more than that, we've got 23 states who have either a 20 or a 24-week ban on abortion. And here's a nice little map. It sort of shows you that it's this, the good old Midwest that is defending life at this earlier stage. So even though we've got these sort of later term restrictions in place, there are still late term abortions. And I left Ohio on here so you could see in 2017 there were still 90 late term abortions, so after 21 weeks. And this is, again, usually they say it's maternal endangerment or for some reason it was rape or incest, and the person changes their mind. Just to point out, my hometown is Rochester, New York, and New York City alone accounts for 1,200 late-term abortions. So if people want to say this isn't happening, like who cares about this late-term restriction, it's still happening. We can't let them say, oh, this just doesn't even happen anymore.
Right.
It's still happening. So, so we really want to be protecting these children. We also have in Ohio the heartbeat bill that Nick was talking about. It's actually called the Human Rights Protection Act. And as soon as the heartbeat can be externally detected in the fetus, depending on the technician, that's between 22 and 28 days after conception, the fetus should be protected. What a great bill. I love this bill, which is now signed into law in Ohio as of April 11th, 2016. However, on July 3rd, right before the 4th of July and the holidays, it was enjoined by a federal judge. So basically the next steps are there's going to need to be another set of lawyers coming in and saying, no, we need to unenjoin this, and there's other reasons. And enjoined means that you stop a bill or you stop a law from being executed because...
Injunction?
Yeah, an injunction. Injunction is what happens when you have enjoined something. So an injunction stops it from happening by saying, oh, this is going to hurt people if this comes into place. It's definitely hurting people by not being in place. So I just want to end this sort of summary with a quote by Thurgood Marshall. So I've been reading his biography just a little bit, and he was the lawyer who brought forth Brown versus the Board of Education.
Right.
And he was motivated by this horrid indifference to human suffering and injustice. And when he said that, I said, wow, this is what we are motivated by too. We are motivated by this indifference. People don't even care about the human suffering we are inflicting on our unborn and this crazy injustice we let go. But I really liked his quote, there is very little truth in the old refrain that one cannot legislate equality, I added, or justice. laws not only provide concrete benefits, they can change the hearts of men, some men anyhow, for good or for evil. And interestingly, I was also talking to my friend who does the pro-life legislation, and we have never, at the federal level, introduced a bill that says, here's the age of fetal viability, and you should not be allowed to abort after the age of viability. So definitely something that would be worth considering. So what exactly is fetal viability, and what role does severe disability play? Before we go any farther in this talk, I really want to tell you that I think we should be defending the unborn from the moment of conception. But I think when we're looking for common ground with people who disagree with us, it's easier to say we at least need to protect children who can survive outside the womb. And so that while it doesn't make these children any more or less valuable to be able to survive, it may be easier to find common ground and find legislators who are willing to push this through and help us. So just a little background, because this can get a little confusing when we start throwing weeks around. Conception
Actually occurs.
Okay, here we go. Conception occurs at 2 weeks gestational age. Now, back when they didn't have such awesome technology as these early ultrasounds we get now, they would just say, okay, when was your last menstrual period? And then they started the dating from then. And so that's why you get 2 free weeks, basically. So fertilization may occur at day 1 of conception, but that would be 2 weeks gestation. So doctors are going to be talking to their patients in gestational age, but research studies are going to use the post-conception age. And so this can get a little confusing. You might hear someone say, oh, the fetal heartbeat starts at 3 weeks. That's true, 3 weeks post-conception. So if you also hear someone say, oh, the fetal heartbeat starts at 5 weeks, this is also true, it's 5 weeks gestational age, because they've gotten those 2 free weeks. So with this, let's take another show of hands. How old was the youngest premature baby to survive into childhood? Raise your hand if you think it's 16 weeks and 5 days. Okay, raise your hand if you think it's 20 weeks and 2 days. Okay, 21 weeks and 4 days. And 24 weeks and 2 days. Okay, cool. You guys are very optimistic. It is 21 weeks and 4 days. So yeah, I saw at least one correct answer here. It would be awesome if it was earlier. And I think we'll talk about reasons why it's not any earlier than it is. But just some fast facts, so things to remember. Basically at this point, October 26th, 2019, if the baby is less than 21 weeks gestational age or less than 12 ounces, the fetus basically cannot survive outside the womb. At 22 weeks gestation, the fetus has a 10% chance of survival in the United States. We'll actually talk about some different countries as well. By 24 weeks gestation, this was actually in 2009, it was 50% chance. It's more like 80% chance now in 2019. And so basically, once you're over 25 weeks gestation, the neonatologist will counsel the parents to resuscitate their child, and most of those children go on to live lives without severe disability. So here's a picture of the most premature baby to survive. Her name is Lila Strenson, and she weighed 14.5 ounces when she was born. Her doctor was Dr. Kashif Ahmed, and he said resuscitating infants who are born in the 21st week of gestation is not standard practice anywhere in the world. But his mom asked, will you try? And he said, I will try. And so this is very exciting also because she also is living a normal life. So oftentimes these children are born with blindness and sometimes severe neurological disorders, and she seems to be developing very well. Not perfect, but you know, she's not even, she's on the normal scale of IQ and things like that. So it's very exciting. Then, a day later in gestation, we've got at least 3 survivors. One in 2017, Dakota Harris, who's the daughter of the Cleveland Cavaliers guard J.R. Harris and his wife Jewel. In 2010, Germany had its first survivor at 21 weeks and 5 days. Her name is Frida Mangold, and she's also, amazingly, not got severe disability. And then in 1987, this is very impressive, James Gill has survived to the age of 30 with no major complications. He's actually in his 30s, he didn't die or anything. And so, very impressively, there are definitely children who are even saved in 21 weeks. And also, pretty interestingly, the rate of survival changes from hospital to hospital. So here in a hospital in Cologne, Germany, the NICU decided they were going to pursue better and better treatments for these extremely low birth weight, extremely premature infants. So they offered very high levels of what they call active care. And so active care is basically you resuscitate the infant, you give them oxygen, and you give them the things that they need to survive. And what they managed was 60% of babies born at 22 weeks gestation survived in their hospital. Now this is basically unheard of in a US hospital. I was looking at some of the US hospital data, and the rates are usually somewhere around 10% in the US. So anyway, we need to go and learn from Cologne, Germany, how we could save more and more of these children. However, there is some scientific skepticism around these earliest gestational ages. Usually the earliest ultrasound you get is going to give you the best prediction of when the child was conceived. This is because the child is growing in a very set pattern and rate, and so the earlier you do the ultrasound, the more accurate you're going to be about when that child was conceived. But the doctor who's responsible for this, for the neonatology and the delivery, are not always the same doctor who was getting that ultrasound. So they might be skeptical that it actually is a child of 21 weeks and 4 days. We also know that larger babies are more likely to survive, but they're also more likely to actually be a little bit older because they've been in there a little longer and grown more. So, that being said, 21 weeks and 4 days is our earliest. 22 weeks, we can get high levels of survival. But in the US, not all of our perinatal counseling is to resuscitate your child. So basically, I was going through a couple of neonatology textbooks to see what is the standard practice. And there's this calculator online that uses data from 1998 to 2003, so this data is almost 20 years old, but it uses this data and it has a model to give you a probability of survival for your child. And the probability is related to 5 factors. So first, how old you are, which is what we could really realistically legislate, is how old the child is. But then also their birth weight, their sex, whether there's more than one baby in there, and the first thing that an OB does when this child is in distress, when there's fetal distress or premature rupture of membranes, they're going to give this baby a steroid shot. They're going to give this mother a steroid shot, and this is going to help their lungs develop. And so if the baby has gotten one or more of these antenatal steroids, they're going to be way more likely to survive. However, this model definitely needs updating. So this is 20-year-old data, and it's still getting used today to say whether or not you should try to resuscitate your child and continue on with keeping your child alive and letting them grow. So it's a very hard conversation because you're thinking about, the doctors are trying to give the parents a realistic view of what might happen with their child. And the parents obviously want their children, but they're also very scared and willing to listen to the neonatologist. And if the neonatologist comes in very pessimistically, it's going to influence how they decide whether or not they're going to say, yes, please pursue everything you can to keep my child alive, or no, we'll just have some comfort care. So survival outcomes are indeed better when the parents in the hospitals choose active care. Interestingly, boys are more likely to receive intensive care than girls. So from the 2009 study, these blue bars are showing what they predict the survival rate would be if there was active care, and the light blue bars show what the survival rate actually was. So basically, as you can see from this, if more people choose active care, more of these babies are going to survive. And so between 1993, so then I was like, we've got to have more data out here. There's got to be something that's been published since 2009. That's 10 years ago. And so I found a study where they looked at 17 hospitals and 34,000 infants. And basically, what's important here is this 22 weeks, 23 weeks, and 24 weeks. So in 1993, 6% of the 22-week gestation babies survived in the US. And in 1993, that number was 52%. But by 2012, those numbers are increasing. So in the 22-week, 9% of those babies survived. And here at 24 weeks, 65% of those babies survived. And then if we look at how many of those babies who did survive then didn't have major disabilities, so cerebral palsy, blindness, things like that. It's not great to be born in the US at 22 weeks. The numbers here stayed consistently at 0. So even if you survived at 22 weeks, all of the babies in this study, except for these two, between 1993 and 1997, had some major disability. And so, even though these babies can survive, sometimes their quality of life is going to be hard. This is just once more showing that the survival rate is increasing, though, over time. And after 25 weeks, the probability of survival is greater than 80%. Yet, even though the survival rate is greater than 80% after 25 weeks, some states still define viability at 26 weeks. And different hospitals are using different standards. So there's a whole bunch of factors going into whether you're at a hospital where one of these extremely premature infants can survive. Most importantly, whether or not they have the right equipment. So you need extremely small breathing tubes and IV lines to fit a very small baby. And so, interestingly, if a hospital is chosen to be stocked with that equipment and try to save these children, the rate of active treatment accounts for 75% of the variation between hospitals. And so, for parents who are deciding that they really do want to keep their children, one of the things that they do is they put them all full of steroids and they take them as fast as they can to a neonatal intensive care unit to deliver their baby there, where they're going to be in a place with the right supplies to keep these children alive. So what exactly do you have to do to keep a child alive in the NICU? And so in the NICU, the goals of resuscitation immediately at birth are you've got to keep this baby warm. You've got to make sure that they can start breathing and using their lungs for oxygenation of their blood. You need to make sure that their heart is working correctly. And we'll talk also about nutrition and getting them the right nutrition. So, having a baby in the neonatal intensive care unit is not like having Manny just born and being able to cuddle him right away. because of some important things. They don't have well-developed lungs at 22, 23, and 24 weeks. So inside your lungs, there's this little coating that helps your alveoli, which is where the gas exchange happens. It helps them, when they sort of collapse, to reinflate again. And if you don't have this surfactant, your alveoli are gonna sort of get squished in and they aren't gonna reinflate. They're like a sticky balloon that has gotten too much spit in it and then you're having trouble getting that balloon to reinflate. So you have to get this just right. You've got to keep the airways open, but you also have to not put so much air in that you actually break the lung open, because that would be even worse. And as you can see from this picture, this is not a simple procedure. You need lots of equipment, and it's scary. It's really scary for parents to be with their children in the NICU. You have to keep their blood volume correct. So you're going to give them little blood transfusions to make sure their blood pressure is correct. And you are going to be monitoring the nutrient levels as the NICU nurse to make sure that they've got the correct balances of glucose and amino acids and all the things that we just get by eating. There are all sorts of interesting techniques to keep babies warm, but my favorite one that I discovered and that is used in a lot of third world countries too is to wrap them in plastic wrap. This actually helps them to stay the correct temperature. Because as they produce heat, it just stays trapped really close to their body. The incubators have warm, humid air so the baby's not losing heat to its environment, and they often have heated mattresses. The one exception to keeping the baby warm is if the baby needs a heart surgery right away. And then they'll actually cool the baby down so that the brain stays healthy during the heart surgery. The baby was not using its heart and lungs to do all of its gas exchange, so its heart still needs time to develop. It's got something called patent ductus arteriosus. Basically, it's letting some of the oxygenated and deoxygenated blood mix. And as that baby matures, the little hole in the heart is going to seal up so that the blood doesn't mix. But it was getting all of its oxygen from the umbilical cord and from its mother. So now the heart needs to start doing almost a different job of getting oxygenated blood everywhere instead of just moving the blood from the placenta around. The baby's skin and eyes are not quite ready for exposure to the outside air. And if this isn't cared for properly, the baby can end up blind. And this baby is also going to be prone to infections. And the worst kind of infection is when the infection gets in the blood, and that's called sepsis. And that's really difficult to treat. So even though we can save babies medically, starting at 22 weeks, this is a hard, hard journey for the parents. Here are a couple quotes from parents who'd been in the NICU. So one mom said that the night after her delivery in her postpartum room, she cried and cried. I had no sleep, just looked at the ceiling and I felt so alone. I was in a separate room, but I could still hear babies crying and mothers getting up through the night to tend their newborns. I still remember the helplessness, jealousy, guilt, and loneliness to this day. My whole body ached for my baby, but she couldn't be with me. And I think this is hard because she has also had the trauma of delivering a baby, probably through a C-section. And so she is recovering, but without that baby in the bassinet beside her. And another mother said other people were taking care of her. The only thing that I could do was express milk for her. And I went home, but I didn't have a baby with me. And I think this is just really emotionally hard for a time when you want to celebrate with the mother. They don't have the baby to celebrate over. And so this is just something that I was sort of laid on my heart, that we should be praying for moms who are who have kids in the NICU and who are making these hard, hard decisions. Okay, so let's switch gears. So the conclusions from Fetal Viability. We can start saving babies at 22 weeks. We want potentially to push more and more to see where medicine can take us. So if more parents choose active care and more physicians counsel for active care, this age could potentially get lower and lower. So finally, let's talk about pain and nociception. What is the difference between these two, and does it matter? So again, I just want to reiterate, I don't think whether or not a human feels pain gives them worth. But a lot of arguments that people make are about alleviating human suffering, and so if we can say, yes, there really is an infant or a fetus experiencing pain, then they want to alleviate that suffering. So as much as I really wanted to come up here and tell you that pain is just purely a sensory component thing, I am also teaching sensation and perception this year, and every textbook I looked at said that pain involves both the sensory component and a cognitive or emotional component. So this isn't just the pro-abortion doctors who were saying this. There is a basis that basically pain is rated on a scale. We don't go into the doctor's office and like put our hand on a measuring device and it tells us you're in this much pain. We tell them, no, my pain is about a 3 on a scale of 0 to 10. And interestingly, in pain, it can also occur in body parts you don't even have. So amputees will often talk about having pain in their phantom limbs. There's something that used to be there and no longer is there. Now, nociception, by contrast, is the sensory component of pain. So if we stick a little electrode into the nerve that is connected to a nociceptor, we can say, this pain receptor is firing right now. And so that we can measure. And we know that pain receptors are in the skin, and we know that they are there actually as early as 7.5 weeks. And we do this by taking aborted fetal tissue and just looking. We stain the skin for these different receptors, and they say, oh look, they're here. We know they're there. And interestingly, newborns actually have more of these pain receptors than adults do. So some areas of our body are more sensitive than others. So this is what's called a homunculus, and it's basically representing your body in terms of how many sensory receptors there are in a certain location. So the hands are huge because we have really good spatial acuity in our fingers. We can feel the difference between 2 little pinpricks on our hands, and again, our lips and our mouth have a lot of sensitivity. So the pain receptors develop in these most sensitive areas first. We can see them as early as 7 weeks gestation in these sensitive areas, and we can see them all over the body by 20 weeks. So basically, from the fingertips and the lips on out, we're developing these pain receptors. And even as early as 7.5 weeks, so basically 3 or 4 days after those first pain receptors can be observed, the fetus will actually show reflexes moving away from painful stimuli. And so the reflex arc is actually, it's sort of this painful stimuli coming in, says, oh no, ouch, comes in, there's a interneuron in between, and it sends a motor command that says, move away from that painful stimuli. And this is basically the first circuit to form. It only needs 3 neurons, and it's going to be the last circuit to die after brain death as well. So, in my mind, if you're moving away from a painful stimuli, this seems like pretty clear evidence that you are capable of experiencing some pain. However, there's a line of thought. This is at least nociception. So this we know. But there's another thought that maybe you need your brain, your cortex, to really experience pain, to understand what you're feeling. So all of this sensory information from that noxious stimulus, that pain, is going to go stop in a brain area called your thalamus before it goes up to the cortex for upper level processing. And pain is going to travel in the spinal cord. So these neurons and these connections, we start seeing them at 13 weeks post-conception or 15 weeks gestational age. And the pro-choice lawyers and doctors have argued that the fetus cannot feel pain until all these connections are in place. Now, if we're going to look at the aborted babies that are out there, we can see all of the connections that we need in this circuit somewhere between 16 and 20 weeks post-conception. And if we look while the baby is inside the womb, so just like that picture of Manny's brain that I showed you on the first slide, we can't actually see as well. And this is because you're using technology that we don't want it to hurt the baby, the fetus that's inside, and it's hard. It's hard to take measurements of a fetus because the fetus is moving around. We've got to get through all the different layers of tissue to see what's there. So we can only reliably find these connections after 26 post-conception weeks in utero, even though we know they're there because of the aborted fetal tissue. So we get to this question, is nociception pain? Well, the burden of proof is on us. We certainly would never knock down a building without proving that nobody is inside. And I certainly don't think that we should knock down the idea that the baby is feeling pain unless we could prove that this baby is not feeling pain. And so, another question, have you ever been hurt without feeling pain? And I was trying to think, because there's definitely arguments to say, oh, you can, soldiers in the battlefield can do these superhuman feats while they're in pain, and they don't feel the pain. But as soon as all that adrenaline wears off, they feel the pain. Like, they are not, they're going to suffer the injury. Even if you can block out pain temporarily, I'm not convinced that you can block it out forever. And importantly, the fetus reacts to pain with a stress response. So actually, even before we can prove all those connections are in place, if we compare two procedures, one that causes the fetus some pain and one that doesn't, what we'll see is higher levels of circulating blood cortisol in the blood. So cortisol is released when you're stressed. And so basically, if you're doing something painful to the fetus, it's responding with stress, which I don't know what's more emotional than the stress response. So even if it is all reflexive, this baby is showing a stress response to pain. The fetus will also show vigorous body and breathing movements in the ultrasound, so moving away from that painful stimuli. And finally, there's a bunch of cool new techniques where people are actually surgically correcting things while the fetus is still in the womb. So spina bifida is often getting corrected in the womb, and there are some congenital heart disorders that are getting corrected in the womb. And interestingly, the earlier you do the correction, usually the better the trajectory outside, but they usually time this for 23 to 26 weeks post-conception, so that if they have to do an emergency delivery, the fetus has a chance of surviving outside the womb. But importantly, the fetus gets anesthetized separately from the mother. And similarly, with those 22-week gestational age babies who are getting born, they are receiving pain management. And so it is sort of ridiculous to me to say, oh, a premature baby can feel pain and we need to manage its pain, but the fetus at the same age, we wouldn't need to manage its pain. To me, I think that's like the most strong argument. Like, we can't say, oh, just because you've changed location, no, your fundamental experience of pain is extremely different. Because that's not how bodies are wired. That's not how we work. So there's also this hard stage of these peri-viable infants, but they receive pain management. So for babies who are born in this time when viability is very questionable, they will often receive something called perinatal hospice, where they do comfort care. And they'll keep this baby alive, but they aren't going to do all of that intensive care that they did, that we talked about. And instead, they'll let the parents cuddle that baby for as long as it survives. And one quote from perinatal hospice: "They heard her voice and gazed back into her eyes as she looked at her parents and big brother. Talia remembered, at that moment, all I felt was peace. It was the most beautiful 49 minutes of my life." And so the other big thing is that doctors will often say, "Oh, there's something wrong with your child, let's abort it." Fetal anomaly is probably one of the biggest causes of these late-term abortions. And I think that really cheapens the parent's experience of what is it like? You've had this child inside your womb for so long, and don't you deserve a chance to spend some time with that child as much as you can? So to conclude, fetal viability is the limit in 19 states. While there's not a clear day or point when the fetus becomes viable, I think we as the pro-life movement should push for a 22-week limit, since we can, with active care, save these children, and depending on the institution, with more or less success. And the Pain Capable Unborn Act is what makes fetal pain important, but it's not what makes these children valuable. So the ability to experience pain doesn't make a human more or less valuable, but it will help people from the other side see our point of view if we can convince them, look, these babies are definitely experiencing pain, and we need to minimize human suffering in the world. So finally, I just want to encourage you, because God knows all of these children. Whether or not we succeed in helping their parents choose life for them, God has got a beautiful plan for them, and we can praise Him because they are fearfully and wonderfully made. But let us be part of seeing justice be seen to be done in the world. So. Are there any questions?
Yeah?
I was wondering what resuscitation means in a prenatal context.
Yeah, so great question. So resuscitation usually involves getting the infant to start breathing because their heart has been beating in the womb, and so you've got to get them breathing. And usually, if they're really, really young, that's going to involve inserting one of these trach tubes, the tube that's right in your throat, to be able to put air pressure in and help those lungs expand and stay expanded. So that's probably the primary goal, but all of it, like getting, just like an adult needs sometimes to get the heart restarted, things like that. There's often a gap in the breathing because the baby isn't quite ready to start breathing, and that is why things might start shutting down. Yep.
Yes, you mentioned at the beginning of your talk, one of your colleagues who was doing the initial basic research on ectopic pregnancy,
Yeah.
whether successful medical intervention can be done. Do you know his name? And if so, is there any way that we can help support his research financially or in other ways?
Yeah, I'm pretty sure he would be thrilled to talk to you. Yep, I can talk to you after and we can connect with him. Yep.
And we would be thrilled to have a speaker on the topic too.
Yes.
Yeah.
But I am wondering, I don't know how accessible this equipment is, but do you think that hyperbaric oxygen could be helpful with these premature babies?
Yeah, so great question. So these babies are actually being given something called usually a high frequency oxygen oscillator. And basically it's like being in hyperbaric oxygen. So you are helping their lungs to stay more expanded and giving them positive pressure. And you're giving them a high saturation of oxygen, usually higher than the oxygen content in our room, something around 60% oxygen. And so that helps them, when gas exchange is occurring, you've got lots of oxygen there. And we want to give these babies the best chance of getting all the oxygen they need, because that's going to prevent those severe disabilities, is if their brain is getting all the oxygen it needs. Yep.
So obviously, obviously like emotionally and psychologically when they hear about this news, about how their baby's not going to survive out of the room, or like the doctor says something like that. But is there like stats of, let's just say like emotionally and psychologically, like the parents, like how they're doing, and then psychologically, how the parents cope when they have that extra like 10 to 15 minutes with their child? Like, is there a difference between that? Is there stats of showing like when those parents have that 10, 15 extra minutes with a child, their coping skills are better? Like, is there like certain stats that you can show people that it's worth it?
Yeah, no, that's a great question. I actually don't know. I have not personally read a study in that, but I haven't also looked for a study on how perinatal hospice influences parental outcomes. Nor NICU. I know there are definitely studies of how the NICU affects parents and like their anxiety and things like that. So it would definitely be worth looking up, and I'd be happy to look it up for you. So, yep.
Yeah, I'm kind of curious, and you talked about surgery, like doing when the child is in the womb, like if they have like birth defects or maybe like heart problem. How do they go about doing that type of surgery, and what is the chance of survival for the baby?
Well, usually the chance of survival is very high when they're doing a prenatal surgery. And typically, so at 20 weeks, they do a big ultrasound where they look for all sorts of birth defects. And if they detect something there, you go for more follow-up and learn as much as you can about what the problem is. And then it's a big surgery, so you're gonna anesthetize the mother, so that's one anesthesiologist. You're gonna anesthetize the baby, and then you're gonna have a specialist who's basically a neonatologist who's working in utero to fix whatever the problem is. And so these are very small, very delicate surgeries and take a long time. But usually the success rate is high, or else they wouldn't be attempting it. They would wait until the baby was delivered and try doing something once the baby is out.
Oh, okay.
Cool, anything else?
That's it.
Okay.
I think we're ready for about 2:15. We will go ahead and have a break for 5 minutes. I think we still need one in the presentation. So we'll take a 5-minute break, and then we'll go ahead and